Director, DTC Scheme, Ministry of Health and Family Welfare, Government of India. He's been an ex-president of Bombay Psychiatric Society from 19 to 20 and a member of Addiction Society of India. Ma'am's areas of interest are addiction medicine and yoga therapy. And I'm sure, ma'am, your valuable inputs and the years of experience you have under your belt are definitely going to make this session very, very interesting and enriching. So I welcome both the chairpersons and hand over the proceedings of today's webinar to the chairpersons. Over to you, Dr. Grover and Dr. Shilpa. Thank you very much.
Thank you, Dr. Nishant and Dr. Rukshida, for the kind words. I would like to introduce the topic, and I think Dr. Shilpa is going to introduce the speaker. So for the topic for the day we have is the use of long-acting pharmacological options for opioid dependence, their effectiveness and ethics. And for this topic, we have none other than Atul Ambekar, who is a very well-known figure in the substance use field in India. We all know that opioid dependence is marked by a lot of lapses and relapses, and that is where there's a problem of continuing the patients on long-term pharmacotherapy. Although we have we have a lot of options in the form of opioid substitution therapy, but all patients are not suitable for opioid substitution therapy, and we tend to use other drugs which are being traditionally used, something like naltrexone in management of patients of opioids. So in today's talk, we are going to learn more and more from Dr. Atul about how to use this long-acting formulations for management of opioid dependence. We all understand that these also form an important part of the whole pharmacopoeia for us when we are trying to manage people with opioid dependence. So with this, I now hand over to Dr. Shilpa to introduce the speaker.
Thank you, Dr. Grover. Thank you, Dr. Nishant and Dr. Rukshida for inviting me here. It's a pleasure to be co-chairing this session with Dr. Grover, and a bigger pleasure to introduce Dr. Atul Ambekar, the speaker for today. Dr. Atul Ambekar is a professor at National Drug Dependence Treatment Center at AIIMS New Delhi, Ghaziabad, which is of AIIMS New Delhi. He's a Secretary General of Addiction Psychiatry Society of India, all of us know, and a member of Board of Directors, International Society of Addiction Medicine. He has plenty of hundreds of publications, awards, and personally, we have been collaborating KM Hospital, the Addiction Center, and NDDTC AIIMS for years together on various projects, be it methadone maintenance and the DTC project, then with the MSJE and NISD last year, where we have conducted online training programs for the first time, where he has been our guiding force. And of course, he was the principal investigator in the National Household Survey that was done to check the magnitude of drug use in India. So with that, and not surprising that he has been awarded with BMJ South Asia Award, Non-Communicable Disease Initiative of the Year in 2016, and National Resource Center NCD's Award for Outstanding Contribution this year. So it's a pleasure that we have him, none other than Dr. Atul Ambekar, who will speak on the effectiveness and ethics of long-term management of opioid dependence. Over to you, Dr. Atul.
Organizers, chairpersons, ladies and gentlemen, friends, thank you very much for this opportunity. I am going to talk about something which is very close to my heart: management of opioid dependence. As chairperson has also remarked in the opening remarks, that this is a challenging area. What I am going to cover today is not the entire gamut of treatment of opioid dependence, just a specific aspect, the long-acting pharmacological options. And even within that also, rather than going through the practice guideline type of issues or giving you the complete review of literature, I will just highlight the concerns which are in the literature, as well as in terms of when it comes to the real world scenario, when it comes to actual practice of using these treatment agents, how they are going to change our practice and what are the important ethical issues involved. So basically, we know about opioid dependence. Opioid dependence is a significant public health issue. Even though there are many more people using cannabis, but in terms of the burden of mortality and the global burden of disease, opioid use disorders have the biggest share, as we can see from this graph made by Louisa Dragonhart. The effective treatment of opioid dependence is on the lines of any other chronic NCD, such as diabetes, hypertension, which means we are talking of long-term pharmacotherapy here. But like any other illness where long-term pharmacotherapy is required, for treatment of opioid dependence. Now, we know this is very, very basic stuff, that the pharmacological treatment strategies for opioid dependence includes the so-called detoxification or withdrawal management, followed in many cases by antagonist maintenance treatment. This treatment, as we all know, is associated with very high rates of relapse, and hence it has very less acceptability among the patients. On the other hand, we do have agonist maintenance treatment with buprenorphine or methadone, which is associated with high retention rate, very good outcome in terms of reduction of drug use, as well as improvement in socio-occupational functioning and quality of life. But on the other hand, there are some other concerns associated with these medicines. So even though buprenorphine or methadone have better acceptability, there are concerns with diversion. And naltrexone, since the acceptability anyway is not very good, the compliance remains a challenge. So basically, that's where the issue of long-acting medications come in. Now, in terms of other areas of psychiatry, particularly the chronic psychotic illnesses such as schizophrenia, we know that long-acting antipsychotics have played a very important role in patients who do not have very good compliance, who have otherwise issues taking medicines every day. Long-acting medicines have really changed the outlook for them. So can something like this, can long-acting medication similarly help in opioid dependence? Now, this is not really a new area. Almost 10 years ago, our colleagues, Siddharth Sarkar and some other colleagues from PGI Chandigarh, they had written a review on this. So which means even at that point in time, there was enough material available to write a review on this topic. So basically, what we are going to talk about is the technological innovations in the form of depot or implant preparations, which are there for naltrexone, the antagonist, and buprenorphine, the agonist treatment. For buprenorphine, there are other formulations also available, such as buprenorphine patches or oral sublingual film. We are not going into that today. We are talking of depot and implants for both these products. Now, as far as naltrexone goes, the long-acting formulation of naltrexone are available as an injectable depot as well as implant. The injectable depot is actually microspheres of naltrexone with lactide and glycolide polymers. The most acceptable strength, most commonly used strength has been 380 milligram. So it requires about once a month intramuscular injection, and then it's supposed to take care of 1 month's opioid blockade. Then in terms of naltrexone implant, we have two different kinds available, striate matrix or a biodegradable polymer. The strength is fairly high here because it's a very long acting. It has to be inserted subcutaneously with a surgical procedure. And then its effectiveness is supposed to last for many months, from 2 to 10 months. As far as buprenorphine is concerned, we have three different kinds of long-acting formulations available. We have buprenorphine implant. At this moment, the international brand name of this is Probufin. Then we have once a month or once a weekly injections in the form of Sublocade or Buvidal. I must clarify here that I'm not really endorsing them. These are the international brand names by which these products are available, and the literature also exists using these products, these names. That's why they are being used here. So as far as comparison of these three kind of long-acting preparation goes, the implant obviously lasts very long, up to 6 months. But then it requires much more resources in terms of training for the provider. It requires some more kind of complexity in terms of if it has to be removed. On the other hand, the long-acting injections, they just have to be inserted, they just have to be injected once, does not really require too much of training for the both these kind of products from the lens of effectiveness and ethics. We will take a more critical look. I'll once again reiterate, we are not endorsing any kind of treatment here, either of them. This presentation is not going to be a practice guideline. So please don't expect me how to manage or how to insert or what's the dose and so on. Also, the idea here is to generally attempt a discussion on approaches we should follow as a profession as far as these newer kind of pharmacological options go. So let's examine the effectiveness issues first, and first for the injection naltrexone, long-acting naltrexone preparations. So one of the very earliest trials, actually, it was a randomized double-blind placebo-controlled trial of placebo with naltrexone, and they compared 2 doses of naltrexone, looked at retention as well as abstinence in the form of opioid negative urine. And as usually these published trials show, best response was with the higher dose of naltrexone, followed by the lower dose naltrexone, and the poorest in retention in treatment was with the placebo. But then they compared injection naltrexone with placebo. We know that even the oral naltrexone has not had very great evidence of effectiveness, very good with oral, even with oral naltrexone. So shouldn't we also compare injection naltrexone with oral naltrexone? And that's exactly this particular study sought to do. Look at this protocol or study design. This is very impressive. It's extended release naltrexone versus oral naltrexone versus placebo. So 3-arm RCT. Looking at objectives such as reduction in drug use as well as cost effectiveness. Looking at many other important secondary objectives as well. So overall looking at quality of life as well as other kinds of behaviors. But the only problem here was this was a sample size. So this was more of a proof of concept kind of study. What kind of methodology should be employed? That kind of study, not really geared to provide definite answers. More of a study design type of study rather than trying to find the definite kind of results. But the most important, the most game-changing type of trial for long-acting naltrexone was this: a double-blind placebo-controlled trial conducted where? In Russia. A 24-week study, a multi-site study, where they compared 380 milligram sustained release naltrexone with placebo as well as counseling. Looked at various outcome measures, decent sample size. In fact, these were the findings which prompted the FDA approval for long-acting naltrexone in US. So just look at this data. 90% versus 35%, 99% versus 60%. You don't even require a statistical test to show which one is more effective. So naturally, this was very impressive. US FDA got impressed and gave approval for using long-acting naltrexone. The only 2 major issues here were this trial was purely funded. This was heavily criticized as soon as it was published. In fact, the same issue of Lancet actually published this particular piece on this trial, a commentary, where the concern was raised that these authors did not do a good analysis of the risk assessment, because one of the known effects of naltrexone treatment is people, when they drop out of this treatment, they lose their tolerance to opioids, and if they relapse, then there is very high risk of overdose and death. That's the effect known with naltrexone treatment, and this is not paid attention to. Also, there is this question that how ethical it is to actually compare naltrexone with placebo when standard treatment in the form of agonist maintenance treatment already exists in many parts of the world. Why did they conduct this trial in Russia? Because in Russia, they don't have agonist maintenance treatment. So in Russia, the ethics committee did not have any problem give approval on the basis of just 1 RCT, and that too conducted in Russia. Nevertheless, the lobbying, the pressure by pharma industry was very, very strong after this. In fact, shortly after this, few years after this, the Secretary of US Health and Human Services, something like our health minister, visited the manufacturing plant of the pharma company and declared that the future of opioid addiction treatment. I'm extremely sorry. I think I was disconnected. Am I audible now? And are my slides visible now?
Yes, yes. Go ahead, please. Go ahead.
If you could,
Extremely sorry.
if you can turn off your video, I think your internet connection would support the presentation better.
Right.
Thank you, sir.
Totally, I understand. So basically, with this, for some reason, I am not even able to stop my video also, but let's leave it. So he commented that buprenorphine or methadone are simply substitutes for illicit drugs. So naturally, this invited backlash. About 700 experts. Am I audible?
Yes, sir. Yes, sir. Your slides are visible
Yes.
and you're audible, sir.
Yes, you are audible.
Yes. Yes. Thank you. So because of this, then many people objected. Many doctors, researchers, clinicians, they wrote a very scathing letter to the government, to this particular gentleman who was the health minister there, and actually recommended that in our country, rather than pushing for long-acting naltrexone, we require better treatment capacity with methadone and buprenorphine, making this all kinds of treatment more affordable, reducing the stigma, and country should have a commitment to harm reduction, which now, of course, US federal government has started saying about. So this was about naltrexone and its controversy. Why there is a need to consider opioid agonist long acting. Now we know that buprenorphine is very well accepted, very good evidence of effectiveness. Is there still a need to consider long acting preparations of something like buprenorphine? So this particular issue was first examined very well, very comprehensively in this 2019 paper in France. Why? Because they looked at France is actually a good country because they have a highest treatment coverage in the world for buprenorphine and methadone, and fairly liberal regime as far as dispensing practices go. Methadone, of course, they prescribe only in specialized addiction settings. Take home is also limited, but buprenorphine is much more liberal, very widely available. There is no urine screen compulsion, and they give take home up to 28 days. I have heard that in the pandemic period, they have in fact increased this duration. And also they have very good evidence that this has worked in that country in terms of reducing opioid overdose, reducing HIV incidence. But they do report that some percentage of buprenorphine does get misused. So that concerns always remains with medications like buprenorphine. One of the earlier studies for comparing this long-acting preparation of buprenorphine, where they compared buprenorphine with double dummy active control flexible dose. So they tried to compare injecting buprenorphine with sublingual buprenorphine as well as placebo. So double blind, double dummy. Important thing was that this was a non-inferiority trial. Now, people who understand trial designs, they understand that analysis, statistical analysis for a non-inferiority is different as compared to a superiority kind of trial. So, but in general, they found that injections were not inferior to sublingual. So as good as sublingual, plus the added advantage of compliance, adherence, and so on. Walter Ling and colleagues, Walter Ling, as we know, is actually the father of buprenorphine treatment from US. So he he and his colleagues, they wrote a very good paper describing the entire process of depot buprenorphine injections from developing to implementation. And after this very conclusive kind of a review, they say that there is really no demonstrated superiority of outcomes using extended release formulations over sublingual tablets. None of these three products actually have had a very enthusiastic response. So the promises of really being a game changer have not been realized with all three kinds of long-acting buprenorphine preparations. Why so? There are some concerns for doctors because there are hassles of undergoing training and the specific procedures that you need to do for implants. Also, they fear the risk of litigation. If something goes wrong, patients may come down heavily for both implants as well as depot injections. For patients, actually, there's a very interesting finding which has come from qualitative studies, and I will come to that. That patients, when they're taking their oral medicines every day, sublingual medicines every day, they have a predictable, stable kind of life where they are happy with how things are going. But with a long-acting, once a month or once a week kind of injection, they're always afraid of what kind of response they will have, whether they will experience withdrawal symptoms or not. And of course, it's very expensive. One of the important concerns with long-acting preparations of buprenorphine is that what to do if the patient needs a full mu agonist. So if the patient requires a full mu agonist for a planned procedure, then you have to go back to sublingual buprenorphine for some days so that full mu agonist can be given. Or in emergency situation, then you just have to have some more intensive kind of measures, including anesthetic compounds. So question also would arise, what kind of patients are likely to benefit from these preparations? Patients who are willing, already stabilized, patients who have high degree of craving, difficulty in abstaining, and so on. The answer here is that anyone with an opioid use disorder who can benefit from oral or sublingual buprenorphine can benefit from this as well. If we inject any other kind of inclusion criteria, we will simply be restricting the availability of this treatment. That's what the early kind of expertise is coming from US. So this was about comparing oral or injectable preparations of antagonists with each other. How about within the approach comparison, comparing agonists with antagonists? So a very interesting study, this again, a non-inferiority trial who compared in an open label manner, took 159 already detoxified patients and compared sustained release naltrexone with our usual sublingual buprenorphine naloxone preparation. Remember, these were the already detoxified patients. So they had already undergone the process of acute withdrawal management. So naturally they found it equal because, as we know, the maximum challenge for naltrexone treatment is actually undergoing the detoxification. That's when many patients actually drop out. Again, a similar kind of trial ex-bot study where they tried to find the differences in opioid relapse-free survival between sustained release naltrexone and buprenorphine naloxone combination. Again, an open label trial, but randomized and with a bigger sample size. Here they found the induction hurdle with both these kind of products. When they compared with intention to treat analysis, the sustained release naltrexone actually fared better than sublingual buprenorphine naloxone. Why? Because with intention to treat analysis, they actually looked at patients who initially dropped out and their data was removed from the study. And as we know, as I was saying earlier also, it's the process of detoxification which is the maximum challenge in terms of naltrexone treatment. So this is the data which shows that really nothing much to choose between these two approaches. A very interesting, very recent study, just a few days ago, in fact, August 2022 publication, where they reviewed the data in terms of outcomes on social determinants of health for long-acting buprenorphine preparations. And what they found was that it was positively associated with improvement in many social domains, not just abstinence, but in terms of employment, relationship, etc. But the qualitative studies, they have concluded that patient preference and individualization of treatment planning is very important issue, which sometimes is not given or discussed so far, is from the experimental design, the drug trials. We know things they work in drug trials may not always work so in the real world. So is there any real world data which we can get some insights about this? This is a very interesting study where they looked at, compared 4 different kinds of medications: injectable naltrexone, oral naltrexone, our usual sublingual buprenorphine naloxone, as well as sublingual or transdermal buprenorphine. They looked at the insurance data, and they found that the lowest discontinuation rates of treatment were with our conventional sublingual buprenorphine naloxone. So much about improving the compliance or adherence with long-acting preparations. Still, in the real world, the best continuation of treatment was with sublingual buprenorphine naloxone. Similarly, Sarah Weckman in JAMA, they published this. They looked at more than 40,000 treatment records and compared various kinds of treatment, either no treatment, inpatient detox, buprenorphine or methadone, naltrexone. And then they very conclusively said, after this real world data analysis, that compared with other treatment, our usual buprenorphine methadone is associated with much more significant reduction in overdose as well as serious opioid related acute care use. So again, emergency room visits kind of thing. Another important aspect which is often missed in this study is looking at the safety issues, particularly the risk of overdose. This particular group of authors, they conducted a retrospective case review of Vivitrol spontaneous reports in the event reporting system. And they found that wherever this information was available, overwhelmingly large majority, the overdose deaths occurred within 2 months of the last Vivitrol injection. So the concerns about discontinuation of injection naltrexone, relapse, and overdose deaths, that does remain from the real world kind of information. Again, a very large scale and very credible kind of publication where they looked at conducted a meta-analysis as well as cost benefit findings for long acting preparations for opioid use disorders. In terms of reduction in opioid use, very modest effect sizes, but injection naltrexone or naltrexone implants or buprenorphine implants, all three, nothing much to really choose from. What they say is still methadone and our buprenorphine naloxone maintenance treatment still have the largest effects of all treatments. Injection naltrexone does reduce opioid use, but criminal recidivism, so in terms of criminal justice system outcomes, doesn't have really much outcomes. And the very clear conclusion that benefits of injection really do not outweigh the cost. So coupled with all the other concerns which you talked about, as well as the cost, doesn't really look like a very encouraging piece of data. This was whatever the effectiveness kind of data we have. Of course, there are some other studies as well, but as I said, the idea was not being comprehensive here. In terms of ethical issues, a very scathing paper which published by Daniel Wolf in about Vivitrol. It offers the fantasy of being drug-free, but the point here is it's not the most important thing in tackling addiction. And this is a very, I think this is something it should be edged in and hung on our wards in our OPD. That idea of addiction treatment is not just making patients drug-free, but bringing about a qualitative improvement in their lives. And that's what actually long-acting naltrexone does not appear to be doing. So in general, any kind of intervention, any health intervention, any medicine, any treatment, it actually gets its position in our treatment systems on the basis of 3 different types of forces. One is the evidence, another is the market forces, and something else is the policy environment. So this may look like very complex thing, but it's really very simple to understand. All of us believe that for most of the treatment of most of the mental health conditions, pharmacotherapy is better than any kind of psychosocial interventions. We tend to discredit or tend to forget how much of this is actually brought out by market forces. To tell us repeatedly that medicines work better than psychotherapy, there are corporations which are making profit out of it. there is no such industry behind psychotherapy. So that also is a factor behind this wisdom that medicines work much better than psychotherapy. Just a crude example, but point I am trying to make is the position taken by any kind of health intervention is influenced by not just evidence, but also by market forces, also by policy environment. And together, the policy environment and the market forces sometimes manufacture the evidence so that we sort of swallow whatever is being offered to us. One of the criticisms of long acting preparations is there are obvious advantages listed here from 1 to 5. No travel, no peaks and troughs, easy adherence, no diversion, no overdose, and the last point is very important here. There is no need for patients to motivate themselves daily to take this treatment. And this is something which many experts, particularly from the human rights perspective, patient rights perspective, are objecting to using this as a paradigm for pushing these products. In fact, Daniel Wolf in his commentary has actually said that this actually looks like the wolf of drug control dressed in the sheep's clothing of medicine. So idea here is to just control people's drug use. It is just given a shape or form of a medical intervention. At the heart of this is the distrust of patients that they won't take medicines as we want them to, and a need to control them to ensure that they are taking this treatment. The common features of addiction treatment programs, both of these. And they say that long-acting naltrexone is just an extension of this philosophy. So, in fact, they say that the pharma industry, market forces, and the criminal justice system have actually started working very closely together in US to push injection naltrexone in the criminal justice system. The manufacturer actually has a dedicated website for pushing criminal justice system long-acting naltrexone. And at this moment, it's used in a large majority of jails in US. And just for the information, a large number of jails in US are currently private jails. So there are private for-profit corporations which are running jails. So we can see how market forces may collude with each other to actually push particular kind of treatment. People have actually called long-acting naltrexone as a carceral prescription, as a jail-like treatment, where the user is not locked in a jail, but her receptors are blocked. The patient's ability to experience any effects of mu opioid agonist has been blocked, and in a almost permanent, almost long-acting kind of manner. And that's why this treatment is increasingly being adopted as the only option available in many jails in US. And this is one of the biggest criticism there. With long-acting buprenorphine, the criticism has been mouthed that here the patient's subjective accounts, whether the dose is enough for them, whether they are experiencing withdrawals or not, whether they still have craving or not, is not really relied upon. Just inject them with this once a week or once a month, and then forget them and then believe that they will be fine. In the real world, there are testimonies of patients. There are forums where patients exchange their own views, and such information exists where patients are complaining, but their providers are not paying enough attention about their dose, about craving, and so on. In fact, one particular group of authors is very strongly advocating for and is conducting quite a few of qualitative studies, looking at patients' experiences of how they are faring with these long-acting preparations of buprenorphine. So basically, if you look at the value system of treatment, the very label advantages of these long-acting preparations, they actually make them more at risk of being used as coercive, forced kind of interventions. So when it is packaged as a new advancement, it's more likely that it will be pushed down the throat of the patient's throat or down their skin. In fact, we know that compliance and adherence, they are the buzzwords in addiction treatment. Patient should comply with what doctor says. Patient should adhere to what the doctor's prescription is. But do these terms actually articulate, actually include patient's autonomy or choice here? Is patients regularly taking our treatment or not? Is it the only thing which matters, or is their choice, their autonomy, their belief that whether they need their medicines today or not, does that also matter? It is said that ethical treatment systems must include everything, all information about the advantages, disadvantages, all the options available, and most importantly, the access to the option of opting out. Now, if I'm taking oral naltrexone every day, if I don't feel like it, I just feel like taking heroin again, I have the option of stopping my naltrexone and going back to heroin. But if I am injected with an implant, then I have to go through the complex procedure of getting it removed if I want to lapse again, if I want to relapse again. And hence, many experts have said that there should be emphasis on not just compliance and adherence, but also on something known as concordance. And a very interesting paper written by none other than our own Dr. Shubho Chakravarti from PGI on concordance. Of course, this publication was largely in context of schizophrenia, but many of the points he made also apply to opioid dependence treatment. So in concordance, basically, we are talking about open discussion with the patient regarding taking the medicines, giving them right kind of information, and giving them the kind of support which they require. Here, it's important to realize that we must respect patients' views, even if they are making those choices which we don't like, which are in conflict with our choices. So that's the value system which we should aspire for, of concordance, rather than chasing the compliance and adherence, which somehow sound like very authoritative, very one-sided. So to conclude, we accept, we know that treatment of opioid dependence is challenging, and the concerns remain about both kinds of treatment approaches, agonist and antagonist. But what we must also realize that anything new is not always better. Technological advancement in treatment do not necessarily represent any improvement in terms of treatment outcome or our patients' lives. More resource-intensive treatment options are not a substitute or a solution for challenges related to restrictive policies. This third bullet point is very important for all of us to remember. There are many people who tell me that since we do not have buprenorphine naloxone available, if the naltrexone injection or implants are available, it would be better for us because we don't have buprenorphine naloxone owing to various policies or financial issues. So that's not really a very wise choice to make, to go for this treatment instead of what is most evidence-based, most acceptable treatment. We need to be careful to ensure that what constitutes optimum treatment is decided by patients and doctors. It is not something which should be decided by criminal justice system or government lawmakers or by the pharmaceutical industry when they push the new innovative treatments to us. Thank you very much, ladies and gentlemen. Again, requesting those who are still not members to join us in APSI. I'll conclude here and be happy to take questions.
Yeah. Thank you, Atul, for a lucid presentation, and I think it has been an informative talk for everyone, that whatever evidence you have presented and the ethical issues which you have raised. So with this, we have few questions in the chat box. So I'll read few of them. You can also read that. This question from Dr. Chaudhary, Iklaq Chaudhary, is that how long we can prescribe buprenorphine? Because the Punjab SOP says don't prescribe beyond 3 years, but practically it is not possible in a lot of patients. So what are your views on this?
Simple answer, which I have been repeating very often in the past as well. Is there any limit to for which we can prescribe mood stabilizers for patients with bipolar, or antipsychotics for patients of schizophrenia, or antihypertensive for patients with hypertension? Basically, treatment is required for as long as the patient needs that treatment. So it really is not bounded by any specific time duration. If we think patient's condition still requires continuation of maintenance treatment, the treatment needs to continue. I have patients in my own follow-up who have been on buprenorphine treatment for more than 10, 15 years now, and many of them are doing quite well. But they know that without this treatment, they won't do well. So at this moment, they are okay, they are fine, they are productive, they are happy, they are away from drugs, they have regained their respect in the society, and everything is going fine. I do not really see any need to stop them, to make them go drug free. So we should go out of this mindset of a particular duration of treatment.
Thank you,
Yeah.
Dr. Atul. I think there's another question, Dr. Grover,
Yeah. Are
about
there
the
any
Indian trials. Yeah.
any Indian trials on the long-acting formulations?
Not to my knowledge, there was an attempt to conduct trial on long-acting naltrexone for for alcohol dependence. But for opioid dependence, I'm not sure of whether any trial is currently ongoing. Though I sincerely believe that despite whatever concerns I have raised today, I sincerely believe that we do require trials and research on these products in India. The point I'm making is, once, even if they are available in India after the due process of trials and approvals, we need to be careful in considering these, looking at various factors.
Thank you. There's another long question here, that there's the strongest flag that all BPNN treatment programs have faced. And the common view is that doctors provide drugs to addicts. How can this mindset be reprogrammed at a policy level? Is it too late to repackage the whole philosophy into a more acceptable one?
Yeah. So thank you for asking this question. No, the answer is not very easy, but gradually I can actually say, with my own experience, with my own observations through the years, the acceptability has increased a lot. The initial barriers were from our own community, our own fraternity. There are quite a few people within our own fold who did not subscribe to the idea of providing so-called addictive medicines to patients with addiction. But those barriers have long been broken now. There is a widespread acceptability within the psychiatrist community, which is a good thing. But even in the policy makers, now gradually we see a very strong improvement. I remember once when the World Drug Report event was being launch was being held in India many years back. The Secretary of Ministry of Social Justice and Empowerment, in response to an NGO's question, very clearly said, this was 2004 year, and she clearly said that we do not believe in giving medicines for a long term for patients of addiction, particularly if the medicines themselves are of addictive in nature. And today, Ministry of Social Justice and Empowerment, through its own NGOs, do not mind providing opioid agonist treatment. In Punjab, the government itself has adopted this treatment at a very, very large scale. And not just the health, but the police department of Punjab is going everywhere and telling the policy makers, please emulate us, please adopt this particular treatment model. So the barriers are being broken. We, the doctors, we, the psychiatrist community, continuously need to be on the job of advocating for the evidence-based, effective, and human right compliant kind of treatment. That would be our job, and we need not, we should not really be lax in doing this.
We have few more couple of questions, so I'll take one by one. Many patients who are on buprenorphine and naloxone present with dependence with pregabalin dependador. So how to manage this situation? This question is from Dr. Roop Sidana.
Yeah, I understand, sir. I understand. Actually, I don't have, I'm not sure whether I have a very good answer to this question. Many patients who are on buprenorphine naloxone actually try some other stuff when their dose they perceive to be not adequate. So tweaking the dose as well as some psychosocial interventions very often takes care of these patients. I mean, pregabalin is still a very fancy kind of stuff. The very more common actually in our practice is alcohol. Patients on buprenorphine, naloxone, abstinent from opioids, but now have started drinking very heavily. So those specific interventions may be required in those regards. Finally, there may be a group of patients whose requirement for reinforcement are high. So possibly these may be those patients who would do well on methadone as compared to buprenorphine. So if methadone is available, then that could be another option. But otherwise, this can be challenging. I understand this.
Okay. Another question again is related to that many patients try to adjust their doses of buprenorphine as per their workload. So how can we help them in doing this?
Yes, it's a very, very important issue here. Now, the dose requirement of buprenorphine naloxone actually keeps fluctuating with season, with change in lifestyle, with some other kind of comorbid illnesses if patients have. For short term, if they meet any injury in some stressful situations, and with change in the work conditions. So whatever requires more strenuous kind of physical labor increases the need of opioids in the body because of fatigue, because of body ache, because of muscular pains, and so on. So that kind of flexibility should always remain in terms of treatment provision. Now, I understand there may be sometimes a mistrust of patients. That patients are asking for higher dose only for the purpose of diversion. They have some ulterior motives. Some other kinds of methods which we employ, such as involving family members, having good rapport with patients. If the dose is very high, then insisting on observed dispensing for a few days before starting take home again. These are some of the measures that can be employed. But essentially, we should be flexible in terms of determining the dose.
Okay. Thank you, Dr. Atul. The next question is one of the basic question. What are the goals of treatment of opioid dependence?
The goals of treatment of opioid dependence, as I'll once again repeat. One is, of course, reduction or cessation of the illicit opioid use, which the patients themselves want to stop. We are treating our patients only because they themselves come to us and say, I want to stop this. That's number one. We are not doing so because someone else, their father or police asked us to do this. That's number one. So that's a very important goal. But that alone is not enough. What's also important is that patients should feel good. Their quality of life overall should improve in terms of their relationship with the family, in terms of their work, their finances, and very importantly, some non-tangibles, such as their reputation in the society, in the neighborhood. So if these other kind of outcomes are achieved, but our patients still continue to take heroin once in a while, I don't really mind. So rather than chasing the goal of complete abstinence, the overall recovery and improvement is much more important, where one or two instances of occasional illicit opioid use should not be seen as complete failure of treatment. That may occur, but along with this, if improvement is sustained in all other areas of life, we should be happy. We should keep the patient engaged with us.
Yeah.
Thank you, Dr. Atul.
Yeah.
There's another question on buprenorphine patch. Can you throw some light on transdermal acting?
Yeah, buprenorphine patch. The idea was quite exciting, but the dosage range which are offered by patches currently, they are good enough for analgesic purpose. They are really not good enough for agonist maintenance kind of purpose. Now we know the analgesic dose of buprenorphine is very low. In the analgesic preparations, actually 0.2 milligram of buprenorphine or 0.4 milligram tablets which are used as analgesics. But for the purpose of opioid dependence treatment, we are giving as much as 10, 12, 14, 16 milligram. So that kind of matching will have to be done by the patches. So patches still remain more in the experimental mode as far as for agonist maintenance treatment is concerned.
Thank you.
The other basic question is, do buprenorphine and methadone produce high in patients?
In patients, I remind you, your question is patients. No? So if you and
Yeah,
me,
yeah.
non-tolerant individuals, take buprenorphine or methadone, we will certainly experience high. Patients who already are tolerant to heroin, who already are experiencing heroin on buprenorphine, they will not experience that kind of high which they experience with heroin. On methadone also, they may experience that kind of high, but only if they take methadone in excessive doses, in high doses, and that too very fast, when the induction is not proper, when the induction is not slow and steady as we do with methadone. So in general, what we call as high, euphoria, pleasure, intoxication, the possibilities do exist. That's what these agonists are actually meant for. But patients who are already tolerant, they are unlikely to experience that degree of high which incapacitates them. What most patients likely to experience is just a level of comfort, which doesn't really put them down and make them not worthy of doing anything else, but just takes care of their craving, withdrawals, and keeps them at a level of satisfaction and happiness, a sense of contentment rather than high.
Thank you. I think that was a very good answer, because that's what our patients, we look for in our patients, that when they are just right dose would be to, feel comfortable, no craving, no withdrawals, and no high. Dr. Rukshida has asked about sexual adverse effects of this treatment and management.
Right. So we know naltrexone, all kinds of naltrexone preparations, they interfere with ejaculatory latency. Since protracted opioid withdrawal is associated with premature ejaculation, with naltrexone treatment, this often gets so one of the important reasons for many young male patients for relapsing while on naltrexone treatment is premature ejaculation. And that problem is likely to continue with injectable preparations. That problem is in fact going to multiply, because with oral, at least patients have this option. I can stop my naltrexone. Perhaps 1 or 2 days I may feel better. I can have my fun or do whatever I want to do, and then again may restart naltrexone. But with an implant, the poor guy has no hope actually, right? If he has to perform sexual intercourse. So that remains a challenge with injection naltrexone treatment. With buprenorphine, that problem is slightly less because buprenorphine being the partial agonist, but still some patients of buprenorphine can complain of ejaculatory problems.
Thank you. There is another question from Dr. Rukshida only. Is it possible for a patient to be a recreational user?
Patients to be a
recreational user.
Recreational user.
Recreational occasional user of opioids, right?
Yeah.
Yes, it is possible. In fact, in the initial phases, most people who present with opioid dependence are those who in the initial phases were occasional recreational users only. However, once the dependence sets in, once they achieve the abstinence, so-called abstinence, then it becomes difficult for them to remain occasional users of opioids without using any opioids on any other days. So that becomes difficult for many of them. Many of them, if they lapse, after some time, they are likely to relapse very soon. So only a small minority of patients will achieve this. I'm talking of those patients who are not on any agonist treatment. Those who are on agonist treatment, many of them still remain occasional recreational users of heroin. Particularly many of our patients, our experience from the northeastern states is such that weekends are for having fun. So patients who are on OST there, they take very religiously Monday to Saturday their buprenorphine. On Sunday they skip it. Sunday they want to have their heroin once again, and from Monday they again want to restart their treatment. So on agonist maintenance treatment, it is still possible. On not on agonist, this becomes rather difficult for the patients.
And yeah, another interesting question is how long-term antipsychotics can help in blocking the reward pathway in non-compliant patients?
Absolutely no evidence so far. So no evidence, no in fact lead also so far. If patients do not have psychotic symptoms, there is no role of what we call as antipsychotics in the treatment of opioid dependence.
There's another interesting question from Dr. Kumar. If injectable buprenorphine is given, but dose is not enough to curb the craving, then is sublingual used?
Yeah, absolutely. If for instance, if we are conducting a trial of injection buprenorphine, comparing it with sublingual buprenorphine, in ethical terms, if I am a member of ethics committee, I would insist that the injection arm should also have the option of supplemental dosage of sublingual buprenorphine as and when required. Otherwise, it will be unethical. You can compare the effectiveness in terms of by counting how many patients required, how many extra tablets or so on. But patients may require in the initial days, particularly if the dose is not stabilized. And that's why when I was talking about those qualitative studies, that's the importance of those qualitative studies, which looks at patients' own experiences, rather than believing just the what the textbooks or the pharmacology books say, that this injection should be enough for 1 week and that's it. We are not entertaining any more requests now. So rather than that, the philosophy should be patient should be able to get relief from their distressing symptoms.
Thank you. Another question is about termination of treatment, how to plan it.
Right. If the termination of treatment is not always a very easy kind of decision, and it should always be in consultation with the patients. The only deciding factor here is attainment of treatment goals. When we think all the goals of the treatments have been met, including sustained abstinence, improvement in productivity, improvement in financial status, quality of life, relationship with family, regained status in the society, and unlikelihood of going back to opioids again, only then we can think about terminating treatment. Should be a mutual decision, should be a slow, long drawn process considering all the factors, and should always be very flexible decision. We should always be able to reverse the decision if required. This is the short answer. Of course, in training sessions, we take a complete session on this particular issue.
Thank you. There's another question about patients complaining of vomiting and headache and insist on tapentadol-based treatment. What may be the reasons in these kinds of patients?
Some patients who complain of vomiting or some other kind of nausea or discomfort with initial days of buprenorphine usually develop a sort of tolerance to it. They start tolerating it very well, even without any intervention and reassurance after a few days. Still, if some patients are complaining of this, some kind of antiemetics, the usual symptomatic antiemetic treatment can very well be given to them, and without any concerns. But there is no logic of giving tapentadol instead of buprenorphine.
I think you have clarified this, but somebody has asked this question: what caused overdose in long-acting buprenorphine? So would you like to clarify that again? Yeah.
What caused overdose in long-acting buprenorphine? Well, overdose risk is much higher with long-acting naltrexone. Long-acting naltrexone, if patients take it, once the effect of naltrexone is weaning off, and that's the time where, because of the antagonist, patients lose their tolerance to opioids very quickly. When they, because of craving, when they lapse and relapse, they may think that my dose was the same which I was earlier before treatment. So I was taking 2,000 rupees worth heroin every day, injecting every day. That's my dose. They would inject that. Now, since they have lost tolerance, it's overdose for them, and then they simply would not be able to survive. That's the reason why in North America, in US, many of the deaths are occurring after patients are on long-acting naltrexone treatment. With buprenorphine, that risk is much lesser, much lower.
Thank you. Another question is about rationale of OST in lactating women.
Rationale. I mean, if the question is about safety, then yes, buprenorphine, women who are lactating, if they require otherwise treatment with opioid agonists, they can be safely given opioid agonists. The buprenorphine does get secreted in breast milk, but not in the dosage, which can adversely impact the baby. So under careful medical supervision, if patients are on our follow-up, we have the good kind of overview of the treatment. Patient and baby can contact any doctor if in case of a requirement. There should be no reason to deny buprenorphine agonist treatment for pregnant and lactating women. In our own ward, we have admitted patients, pregnant women with opioid dependence, in the second trimester, saw them through the entire pregnancy period, got the baby delivered, and all this while their buprenorphine treatment was continued, and the baby is now grown up to be fine, healthy baby.
Thank you. There's another $1 million question here. Can we use Vivitrol in India if patient gets it?
The product has still not been approved by CDSCO for use in India. So if at all you will be prescribing it, you will be doing an off-label kind of use of a product which is still not been approved by the government here. And if something goes wrong, then I'm sure we'll be willing to face the music. But so that's it. I mean, at this moment, it's not approved in India. If we are feeling adventurous, nothing stops us from doing that.
Okay, thank you. And there's another question about policies. What is legal, illegal in Punjab regarding various preparations, patch, implant, injection, buprenorphine injection in Punjab?
Availability of or approval as a pharmaceutical product for any product in the country is not state specific. So once CDSCO, the Central Drug Standards Control Organization, gives approval for a product, the approval is now for the entire country for marketing and for prescription and dispensing. So there is nothing which is different for Punjab, legal or illegal, versus other kinds of states.
Thank you. There's another question. If patient wants to stop buprenorphine, how to evaluate and manage? Dr. Siddhana has asked.
Right. If patient wants to stop buprenorphine themselves, we need to first of all engage the patients once again and assess whether this is just the bravado and overconfidence that now I can stay away from medicines and I'm now fine, or the goals of treatment have genuinely being met. So that kind of psychoeducation is very important for the patients. We do all this. We do this for our bipolar patients also. We do this for patients of various other conditions also who want to stop their treatment. But when we believe treatment must continue. So we should do that exercise here as well. In spite of that, if the patient still wants to discontinue against our advice, then of course we should offer this help to them with all kinds of precautions, with all reassurances that we are here in case you require us again.
Thank you. There's another last question, I think. If buprenorphine or methadone is not available in an occasional user, then can we start on a trial of daily oral naltrexone and clonidine?
Well, if you are saying, as you are saying, the patient is occasional user only. If the patient is occasional user only, the patient is unlikely to be suffering from opioid dependence. And such a patient may not really require long-term pharmacotherapy. Such a patient may require what we call as brief intervention or motivation enhancement. Certainly not agonist maintenance treatment. Agonist maintenance is required only for patients who meet the criteria of opioid dependence, not for non-dependent users.
Okay, I think we are coming to the end of the question answer session. One last final question is that why buprenorphine plain is not available in Punjab, whereas plain formulation is available in other states like Haryana and Rajasthan. So I think these are a policy matter. If you can take up this.
Yeah, I mean, not available means do the manufacturers do not supply it if you ask for it? That will not be the case. So any hospital, any manufacturer, if they any clinical facility, if they need buprenorphine, and since it's approved by CDSCO, you can order it and you can get it like any other hospital in India do. So there is nothing. I think when the question says not available, possibly it's by the government's OAT program where the treatment is being dispensed. That's where government has decided that they will dispense only buprenorphine naloxone. So that's a policy decision to prevent diversion.
Okay. Yeah. So thank you, Dr. Atul, for a lucid presentation and taking up all the question answers. And now I hand over to Dr. Shilpa before she hands over to the organizers. Yeah.
Thank you, Dr. Atul, and thank you, Dr. Grover. It was a pleasure to chair this session. Thank you for inviting me.
So thanks, Rukshida. Please take over.
Thank you so much, everyone. Before we actually end the session, I think we have a few colleagues from Sri Lanka who are quite interested in the topic, especially because we have such a stalwart talking about it and such an expert talking about it. So we welcome them. We occasionally do have colleagues from our regional countries in the past as well. So it's really nice to know that if nothing else, the pandemic has helped us cross those boundaries and break those barriers. At this point, we are also joined by Dr. Rupinder Kaur. So in case Sir wants to share a few words with us, it would, and we welcome his wisdom.
Thank you, Rukshida. So nice of you to remember me. I have a few questions, or let's say my request outside what Dr. Atul has said. It was a very lucid presentation, and also it cleared many doubts about long-acting preparation and also the current situation. But I want to know why the Addiction Society of India, which Atul is heading, cannot become more unionist, because in Punjab we are suffering from the hands of the government and the common man at the same time. We are being labeled as criminals, both the doctors and the patients. And if the AIMS and PGI come together to help us, to free us of this bondage of being criminals while dispensing the drugs, because the SOPs which needed to be modified have not been modified since 2014, as they were supposed to be modified within 3 months. And I think Atul is the right person. There is Dr. Sandeep Grover, then there is Dr. Devashish Roy. They should formulate some policies which are good for the psychiatrist, I mean safe for the psychiatrist, and also good for the patients. These SOPs are so draconian in nature that we cannot give the patient the medication he needs. And what he does is, when he goes outside the OPD, he goes and says, let's go to Bhukki, that means opium husk. So what's the purpose of this kind of regulations which the Punjab government is forcing upon us? So if these people, I mean IPS and Addiction Society of India, they become more trade unionist and engage the Punjab government to solve the problem of the people, because we, the doctors, are helpless. If we cross the boundaries, we go under the hammer of the NDPS Act. And if the patient whom we do not give the adequate doses, then he goes back to the illegal drugs. I hope Dr. Atul and Dr. Sandeep Grover will take note of this. And on this note, I thank everybody who asked me to give my own comments. Thank you so much, Rukshida, and everybody else.
Thank you, sir. Also, a few interesting and announcements. If I could invite Dr. Jyoti Shetty to share a few words, and she has some nice information for us to cheer us more.
Yeah. Thank you, Dr. Rukshida, for inviting us. And Dr. Ambekar, that was wonderful. We do not see so much of opioid addiction in Pune anyway. I'm from Pune, and at the outset, I'd like to say that we are very thankful for this opportunity of co-organizing the annual national conference of the IABP, the 18th one, which is a virtual conference on the 24th and 25th of September. I think Dr. Rukshida will soon be putting out all the the forms and the posters regarding the same on various groups, but this is just an initial sort of alert for the same, and it is an honor. It's the first such program. We are a very small team, and we would love to have you attend. It's a virtual seminar, we are virtual webinar, so web conference. So I'm sorry we can't say welcome to Pune, but anyway, virtually we'll all be there. Thank you very much, Dr. Rukshida.
Thank you, Dr. Jyoti Shetty. We're really looking forward to the 18th annual conference of the Indian Psychiatric Society. And we wanted to keep it virtual again this year for easy accessibility for a lot of people, because a lot of people still are hesitating to travel, and we are completely cognizant of the fact, and we appreciate the enthusiasm still that biological psychiatry psychiatrists are showing, so that we can continue the work that we're doing. I would now take pleasure to invite my Joint Secretary of IABP, Dr. Majid from Srinagar. He's going to do the most important job of the day. That's the word of thanks.
Thank you, Dr. Rukshida. It's always a pleasure to be part of a program where you have a speaker, a stalwart in addiction psychiatry. As far as India is concerned, Professor Atul Ambekar, it's always a treat to listen to him and acquire as much as knowledge you could. Thank you very much, Chairperson, Dr. Sandeep Grover and Dr. Shilpa, for your contribution in the program. You have made it very interactive, and Dr. Nishant Goel, my dear friend, from CIP, who kick-started the program initially, and in between, we had very wise comments and concerns actually by Dr. Rapinder Kapoor, who is a very, very senior psychiatrist of North Zone, and Dr. Jyoti Shetty as well. Thank you very much for giving us update on the upcoming annual conference, although in virtual. Thank you, everyone. And last but not the least, Dr. Rukshida has been very pivotal in organizing these programs, and thank you IABP team, IABP office bearers, and all attendees especially who have been there. As Dr. Rukshida said, we had from Sri Lanka, and within our own India there are a lot of people who attended today's program. Thank you everybody, and we'll see you very soon. Take care, good night, all the best.
Bye. Thank you. Bye.
Bye. Thank you.
Bye-bye. Take care. Bye.
Thank you, Shilpa ma'am. I think Sandeep's gone. It was a good discussion. Thank you so much for participating. Bye. Good night.
Good night.